So I'm going to talk to you today about neuro-ophthalmology. This is again a very important topic and quite complex in its own way. So I'm going to try and make it simple. I'm going to cover only a few common conditions relevant to your practice, also relevant to the examination, as some of these topics will be definitely asked of you in both the theory, and you could get this in the practical as well. So the loss of vision is a very challenging clinical problem. It's a loss of visual acuity with obvious structural abnormality in the eye to account for it. But there could also be sometimes conditions outside the eye that could cause this. So an unexplained loss of vision could be optical, that is within the eye. It could be neural in the optic nerve or the pathway, and it could also be psychogenic, and it's important to try and determine what the cause of this could be. So how do we approach an unexplained visual loss? We do some potential tests for acuity. If the acuity improves, then the problem is probably in the cornea or it's a defect in the lens. If the acuity is not improved, we do a swinging flashlight test in which we take a flashlight and we look at the pupillary reaction in one eye, then the other, and as we swing it from eye to eye, generally you will notice that where the light is swung, the eye tends to constrict, the pupil tends to constrict. However, you could get a paradoxical dilatation of the eye, which is called a rapid afferent pupillary defect, and we'll talk about it in a bit. And there's also tests of color saturation, brightness, contrast sensitivity, and if the swinging flashlight test is positive, particularly if it's involving one eye with color desaturation, one would think optic neuritis. So if you do a swinging flashlight test and the RAPD is not present, then of course you test for any retinal involvement, and if the retina is okay, then we look for any evidence of amblyopia. On the other hand, if there's no evidence of amblyopia, then look at the visual fields. If it's a bitemporal heminopia, then it's likely to be a chiasmal lesion, usually a pituitary lesion. If it's or a bilateral nerve fiber defect, optic neuritis, which is rare, it's usually unilateral, or it could be a retinal artery or retinal vein lesions, which tend to be more catastrophic and more acute in presentation. And of course, if there's non-specific depression, constriction, now one could think of optic neuritis. Optic neuritis usually produces a small point of defect of vision called a scotoma. Psychogenic issues can also present with all sorts of bizarre manifestations, and if everything is normal and there's unexplained vision loss, we would obviously think of psychogenic issues. On the other hand, if there is evidence of if there's a positive test, then you think of various conditions as in this very busy slide, and I do apologize for that, but I wanted to give you all the information. Definitely do think of various forms of optic neuropathies and the conditions that are mentioned there. So just to recap this, swinging flashlight test, RAPD present, do a visual field evaluation. If there is a heminomic field defect, then it's likely to be a chiasmal lesion, and if it's a non-heminomic defect, then think of optic neuropathy or a retinopathy. Now, we're not going to go into more complex ophthalmology here. This is outside the remit of this talk, and certainly will not concern you who are going to give a medicine exam. But optic neuropathies could be typical, atypical, or non-inflammatory. Typical optic neuritis is a very common presentation, especially in young women in this country. It presents with a unilateral painful reduction of vision. It comes on very suddenly. It's like most of them describe a very blurry vision, looking through a film of grease. Onset is over generally hours to days, and could be the forme fruste or the first presentation of MS. There is no redness of the eye. Actually, there's no problem in the eye whatsoever. The problem's in the eye nerve. And they develop color desaturation. Red starts looking as brown. They have an RAPD, and 70% have a scotoma, which is a tiny loss of spot of vision loss in the center of the eye field. And some of them will show blurring of the optic nerve head because it's inflamed. It's not, it could be partly swollen, but it's not papilledema as such. Papilledema, interestingly, is bilateral. It'll be very rare that papilledema is unilateral, and papilledema is not accompanied by vision loss. That's how you distinguish between papilledema and optic neuritis. Optic neuritis is a primary inflammation of the optic nerve. There are two forms: papillitis, where the disc swelling is present, so it's the papilla or the optic nerve head that's inflamed, or retrobulbar neuritis, where the optic disappears normal, but there's pain on eye movement because it's behind the disc as the eye nerve forms, where the inflammation takes place. The pain is periocular, it could be retrobulbar, it could be tenderness of the globe. The pain, especially on eye movement, contrast sensitivity is abnormal. 90% of patients will otherwise have normal visual acuity. There's a rapid afferent pupillary defect. The visual field effect could be a central scotoma, and there could be some a little increased cellular cells in the vitreous as because of the inflammation. So the examination is generally normal, especially if it's retrobulbar. There would be a little bit of swelling or blurring of the disc margins and look pinkish and inflamed. As the neuritis resolves, the disc becomes pale, almost chalky, like a new moon, especially if they've developed optic atrophy over a period of time. And this is patients who have poor visual acuity. So what's a clinically isolated syndrome in the context of MS? A patient could get one attack of one neurological syndrome. Usually it's optic neuritis. They'll have a bit of white matter lesion, so it will make you suspect that this patient's got more than just the eye nerve involvement, but they'll have no further attacks. So it'll be just one isolated attack. It's called clinically isolated syndrome. Could we predict whether the patient will develop MS or not? If the MRI lesions are significant, then the ONTT stands for the Optic Nerve Treatment Trial, which was a big trial in which lots of sub-arms were there, and so lots of other studies came out of it. But if there were MRI lesions suggestive of MS, then 75% went to develop MS in the next 10 years. If there were no lesions, then it was less than 20% people. So what do we do when we have optic neuritis? When we've done our clinical examination, we can do a lumbar puncture apart from an MRI to look for oligoclonal bands. We can also do a visual evoked response study in which we put some electrodes on the head. We stimulate the eye field by giving them a pattern to look at. Usually it's a checkerboard pattern, which are rapidly changing squares, and we read the time it takes for the impulse from the retina to the occipital cortex. Usually it's about 100 milliseconds. If it's prolonged, then there is damage to the eye nerve, and that's called an abnormal visual evoked response treatment. So what we do, corticosteroids has been the mainstay. If the patient comes within the first 2 weeks, we give a pulse of therapy with methylprednisolone, usually 1 gram for 3 days with stomach and bone protection, or we can give oral steroids, but we don't follow up usually with oral steroids. 1 pulse of either oral or injectable methylprednisolone is given. And even if you were not to treat, most of these resolve on their own. But in a high dose of intravenous steroids does show immediate response because it reduces the inflammation, but over a 6-month or 1 year visual outcome compared to placebo, there was not much change. And so these are what the NICE guidelines also say. Now, what is NMO? The NMO is a new concept. It's over the last few years we've learned more about it. It was initially thought to be optic or spinal form of MS, but recent discoveries indicate that these are two distinct diseases. So basically, there's a long segment of the spinal cord, more than 2 or 3 segments of the spinal cord involved with optic neuritis, in which there's eye pain and vision loss, and they can present with a transverse myelitis with a sensory level and weakness of the legs. The NMO basically is tested by testing for an antibody in the bloods of individuals with NMO, which is called the NMO antibody or the aquaporin 4 antibody, and the antibody is present in 70% of cases. It will not be present in patients with MS because there can be overlap in this condition. And of course, NMO is treated with steroids and anti-inflammatories, and There are many variants to this, but that's outside the scope of this talk. Now, atypical optic neuritis, we talked about typical optic neuritis, is basically could be infectious. So there's a whole host of infections that is mentioned there, including meningitis, encephalitis, syphilis, toxoplasmosis, and Lyme's, etc. There are also other conditions which are mentioned, including connective tissue disorders, lupus, and sarcoid. And of course, there's non-inflammatory optic neuropathy, which could be compressive or infiltrative, as in cancer and radiation linked. It could be a Leber's, which is a hereditary optic neuropathy, toxic, as in methyl alcohol or even excessive alcohol consumption, nutritional with especially B12. And you can get optic neuritis even with raised intracranial pressure, and then glaucomatous optic neuropathy. You must know about 2 or 3 neuro-ophthalmology conditions. So we've talked about optic neuritis. The next one you should know about is giant cell arteritis, because this can be quite a dreaded condition. If you miss this, the patient can land up with blindness, and therefore one needs to have a very good idea about this. It's an idiopathic vasculitis, involves the medium-sized arteries. The temporal artery gets inflamed. It's the same disease spectrum as polymyalgia rheumatica. It usually affects women in the age group of 65 to 80 years, but men are not exempt from it. It's the medium and large arteries in the head and neck that are involved. So what happens in this? Basically, what we're worried about is the ocular complications. So they present with a transient monocular vision loss, and then they can develop a complete vision loss. Now, a transient vision loss can be basically in a stroke like TIA, amaurosis fugax. It can be due to retinal artery occlusion or anterior ischemic optic neuropathy, which is what happens in giant cell arteritis. It's an optic neuropathy, but here the pathology is that it's a vasculitic lesion of the optic nerve, and it presents with sudden loss of vision. Once the vision is gone, it is permanent. So compared to the temporary vision loss that's already been mentioned, here it's a permanent vision loss, and it will not come. So people can lose their vision. Therefore, any elderly patient presenting with a headache with tender temporal arteries, or even if they're not palpable, should be treated as giant cell arteritis till proven otherwise. A biopsy is very confirmatory, but remember that the artery can have skip lesions, and sometimes you have to do a long segment of the artery to pick up the diagnosis, which is obviously harmful to the artery itself. So it's a tricky one. Ultrasound Doppler of the temporal artery can sometimes give us a clue, and if positive, confirms the diagnosis. Especially if the biopsy is positive, then it's 100% the same. We do a ESR and C-reactive protein, which is available to us on the bedside, which is an ideal test. It's easily done, quickly done, and they're generally very raised in this condition. If someone presents with this, sometimes you may not even have vision loss, but one of the only vision symptoms that you might have in this is diplopia. And you do a CRP and ESR, and if it's raised, you immediately start this patient on steroids. In fact, you don't even wait for the CRP, ESR. If the suspicion is high, give steroids till proven otherwise that this is temporal arteritis. So basically, intravenous and oral steroids are, and these patients might need steroids for a very long period of time to manage this condition, and may need to be observed and monitored for a long period of time. So this is giant cell arteritis. There are a couple of clues in the history which might help you, and apart from the headaches, which are mostly around the temples, the patients might complain of tenderness over that region, and you can feel a thick and tender temporal artery. They can also have jaw claudication, so when they eat, there's a spasm in the muscles of the jaw because there is compromised circulation because of vasculitis, and they can develop claudication. They can also develop scalp tenderness, so they will complain of pain while they comb their hair. These 2-3 symptoms can be very, very important as a clue to the diagnosis of temporal arteritis. Right. The last condition I want to tell you about is benign intracranial hypertension, BIH. Basically, this is a patient who will present with symptoms of raised intracranial pressure. They can present with headaches and visual blurring, but the vision is generally intact. As I mentioned, papilledema doesn't cause loss of vision. This is a condition seen in young women of childbearing age who are quite grossly overweight, and they will present with headaches and some vision problems. Early vision issues are mostly just flashes of light, or they'll complain of slight blurring. But otherwise, the patient is fine, absolutely alert and awake, and fully normal in neurological evaluation. The neurological examination is completely normal. Occasionally, if the pressures are very raised, you can get a false localizing sign with a bilateral 6-nerve palsy. The CSF is completely normal in these patients, but they will have raised CSF pressures, and there is no other problem in the circulation in the brain when you do a brain scan. So basically, these patients, as they present with headaches, you have to have again a high index of suspicion, because patients end up losing their vision if they're not evaluated properly or treated properly. We do a visual acuity, we do a fundus evaluation, we also do a test called an OCT, which is an ocular coherence tomography, which is basically a scan through a section through the optic nerve head, which will show that there is increased fluid between the retinal layers and they look very swollen. And then fundus photographs are taken so that next time patient comes, there is a scan for comparison. We do an MRI. The MRI will show certain findings like an empty cella, flattening of the posterior sclera. There'll be enhancement of the optic nerve, and also the optic nerve sheets may be dilated and a bit tortuous, and there could be a little protrusion of the optic at the optic exactly on the globe, with flattening of the sclera there. MR venogram is always done to rule a cortical vein thrombosis. Then we next proceed to a lumbar puncture to measure the opening pressures. Patient's leg extended. It's extremely important to do it in the lying position with the head and spine and the same line, so that gives us an accurate pressure. If you do it sitting up, you'll get a false reading. You measure the opening pressures. Normal CSF pressure is 9 to 20 centimeters of water, and if it's raised, you bring it down and close the pressure around what there's an error in that slide. I'll correct that. It should be around 20 centimeters of water. Send it for cell count, proteins, glucose cultures, etc., so that you exclude any other causes. But basically, raised pressures with no other cytology or biochemistry or microbiology involvement is the usual picture. What should you exclude? Well, you exclude a cortical vein thrombosis. You rule out a CNS malignancy. You'll be surprised how many tumors land up when you do a brain scan. And it's always important to do an MRI rather than a CT. The other causes of CNS inflammation are excluded, and of course you have to make sure that there's no optic nerve head drusen, which makes the optic disc look swollen, but is not papilledema. So how do you treat this condition? Basically, medical treatment. The most important treatment is weight loss. Acetazolamide is the drug of choice. If the patient can tolerate it, it's teratogenic, so you need to warn them that not to get pregnant on this medication. And usually we give 250 milligrams BD, then 3 times and up to 4 times. We can go up to 1000 milligrams 4 times a day, but usually 1000 mg or 500 mg BD is more than enough. And most patients will not tolerate a very high dose because it causes paresthesias of the fingertips and numbness around the lips. Topiramate is anti-epileptic, but it's also got a very good, excellent role in headache management and also lowering the pressures. Usually 25 mg BD increased up to 50 mg BD and beyond. Diet is extremely important, so mainly to lose weight. Steroids have been used by various people, but steroids can paradoxically raise the intracerebral pressure, so we don't use them, and that's why I put it down to mention that. We do lumbar punctures. Sometimes you need to do serial lumbar punctures as patients' pressures take time to come down and it's difficult to adhere to a diet and reduce their weight. The patients who do the best are the ones who manage to reduce their weight. If they're pregnant, we stop the acetazolamide, but we do serial lumbar punctures depending on the vision findings every 2 to 3 months. At the time of delivery, they have papilledema, then they go in for a cesarean section. If they're going in for a normal obstetrically normal birth, which is basically there are no papilledema, but patient under close monitoring, then we try to cut short the second stage of labor and use epidural anesthesia, because all the other anesthetics can raise the intracerebral pressure. If patients develop a more severe form of benign intracranial hypertension and vision is at risk, then we send them off for a shunt, either a VP shunt or a lumboperitoneal shunt, so that they can CSF drains away into the abdomen, and they're able to maintain their intracerebral pressures. And of course, in some cases where there's narrowing of the cortical veins, especially the transverse sinuses, a stent can be placed, which is quite useful. This is about the 2 or 3 neuro-ophthalmological conditions that I think you need to know about. The rest, I would suggest you have a read about these conditions in a little more detail, because these are common conditions and one would need to have more than a working knowledge of managing such patients. Thank you.